given to us with syncope. So this picture of a goat that you see on the screen actually shows what's called a fainting goat. This is a separate breed of goats. They don't have syncope per se, but when they are startled, they have a myotonic response. So they just go into a form of myotonia. So they have a congenital or hereditary problem that runs in the breed. So this is, just to know that not only do humans faint, but goats faint too. Now, the approach to this presentation will be case-based. And as we discuss the cases, hopefully we will also learn about syncope and aggregate knowledge. Okay, so let's start with this scenario. 1-year-old presents to accident and emergency with a history of being unwell over the past 2 days with fever and poor oral intake. In the morning, parents have found him unconscious with a bit of drooling, and they've brought him to A&E. So when he comes to you, he's not arousable. He's got a bit of a temperature. His temperature is 40. What do you think? I mean, we know that syncope is a state where there is a loss of consciousness. Do you think that this patient has got, has had a syncopal episode? How would you describe the neurological or the general state of the patient? Would you call this an episode of syncope? So it's going to be interactive. So I have the chat box open so that people can type their responses and we can discuss. Everybody can see your response so that everybody learns. Right. So you say it's probably not syncope. Okay. Maybe hypoglycemia, maybe febrile seizure, maybe a lot of things. But can you tell me why you think it's not syncope? Why is it not syncope? What are the features of syncope? What would you call an episode of syncope? Why is this not syncope? Come on, guys. You all said it's probably not syncope. You're thinking of various other diagnoses. But what are the features of, that would indicate syncope? And what are the features, which are not there in this patient? Okay, how would you define syncope? Let me rephrase that. What are the characteristics of a syncopal episode? What are the characteristics of a syncopal episode? Okay, right. So syncope is a sudden event. It's a sudden loss of consciousness. It is transient. It's very important. So it's transient. So this patient is continuously unconscious. Okay, so this is not an episode of syncope. So it has to be a sudden and a transient loss of consciousness with a loss in muscle tone, which makes the patient collapse to the ground. However, after the episode of syncope, the patient usually recovers completely back to normal. Okay, so if you go by that, this patient does not sound like he has syncope. So there should be a complete loss of consciousness for us to call it syncope. It has to be rapid in onset or sudden, and it should be of short duration with a loss of postural tone. We mentioned all of these things. Okay, and there will be a complete recovery at the end of the syncopal episode. So this patient, like many of you pointed out, now he's had fever, he has, he's unarousable. So either it could be a febrile seizure, or it could be an encephalopathy of some sort. Maybe he has meningitis, meningoencephalitis, something else to explain his altered consciousness and his temperature. But this is not an episode of syncope. Okay, so now we know, we have gone through the exercise of defining syncope. What is syncope? So syncope is a sudden and transient loss of consciousness with a loss in muscle tone And usually there is complete recovery or after the episode of syncope. Now, you will be, surprised to know that the incidence of syncope is quite high. So nearly 50% of children sometime during their childhood will have an episode of syncope. So it's a very common occurrence. That's what I said right at the beginning. It's a very common problem. You see it often. Most often it is benign, okay, and nothing to worry about. So all that the patient needs is reassurance. However, there are instances where it may not be benign, and this is what you need to tease out. So the whole point of you as a cardiologist seeing a patient with syncope is to identify those patients who have malignant syncope or non-benign syncope. The majority of syncope is neurally mediated. Okay, and the neurally mediated syncope includes the most common type of syncope, which is vasovagal syncope. Okay, so there are a small number of neurally mediated syncopes where the mechanism is due to, using the autonomic nervous system. So most of them are neurally mediated. Then you have the psychogenic syncopes as well, which don't have a real organic cause. So that constitutes a proportion of patients as well. And it's the remaining that would include the cardiac or cardiogenic syncope. So a majority are neurally mediated. There's a small proportion which may be psychogenic. And in addition to that, there are other pathologies which include cardiac pathologies. So broadly, syncope is classified into autonomic syncope. There are various ways of classifying syncope. So you can choose one that you like, but this is one of the common classifications. So autonomic syncope includes vasovagal or neurocardiogenic syncope. These are the same, just two different names for the same problem. This is the most common cause of syncope. Then there are syncopal syndromes where there is inappropriate tachycardia. Okay, and so these fall under autonomic syncope. There are also some special syncopes, again autonomic, which are called situational syncopes, where this syncope can happen during voiding of urine or during swallowing. So these are also a type of autonomic syncope. Most of these syncopes, that are autonomic are benign syncopes, nothing to worry about, nothing serious, and no real risk or threat to life. Then you have the dangerous ones, which include the cardiac syncopes. So this could be either due to a mechanical problem, or it can be due to an electrical problem. So either due to an arrhythmia or some mechanical issue that is giving rise to low cardiac output and syncope. Like we mentioned earlier, a small proportion would have neuropsychiatric syncope. And then you have miscellaneous things like hypoglycemia, etc., which come under the metabolic category. So this is one way of classifying syncopes. Okay, so now that we have done some theory, let's look at some case scenarios again. Okay, so a 9-year-old is brought to your clinic with a history of fainting while standing at assembly at school. So have all of you come across this kind of a story in your clinical practice? So what do you think is the etiology, we discuss the various types of syncopes, the classification of syncope. So which classification do you think this will fall under? Guys, I'm waiting for you. I hope you can hear me. Okay. So this would, yes, it sounds typically like a vasovagal syncope, right? So, or neurocardiogenic syncope, where it's an autonomic phenomenon and there is a vagal stimulation. In terms of the mechanism, it is thought that often the thing that brings about vagal stimulation is an initial sympathetic stimulation, like an adrenergic surge, that then causes a parasympathetic response from the vagus. So there is a vagal stimulation which results in vasodilatation, okay, bradycardia perhaps, and an episode of postural hypotension and syncope. Okay, so this sounds typically like a vasovagal episode. However, you can't just, assume it's vasovagal. You have to go through the exercise of taking a detailed history, doing a good clinical examination in order to conclude that this is vasovagal syncope. So what is the most important investigation for a patient who presents with syncope? What is the most important diagnostic tool for a patient presenting with syncope? What is the most important diagnostic tool for a patient presenting with syncope? I'm not agreeing with the ECG. Correct. Exactly. So the most important tool for a patient presenting with syncope is history. History, like you've written in the chat box. So, again and again, the first, second, and third most important tool is history. Okay. So history taking is critical. If you ask the patient, so it's important to ask the patient to describe the symptoms associated with the syncope. Often there are characteristic features associated with vasovagal syncope. So they can have nausea, sweating, some kind of visual disturbances. They may have a feeling of lightheadedness even prior to the actual loss of consciousness. And from the history, many a time, this episode may be associated with postural change, so when the patient is standing up from, sitting down or from lying down, that's when the syncope might occur. So all of these, just from the description of the syncope, you may get a clue as to the fact that this is a vasovagal episode and nothing really to worry about. Now, in addition to taking history about vasovagal symptoms, you also have to exclude other, pathological causes of syncope. So can you list out certain, histories that you need to elicit? What are all the things you need to ask the family regarding the syncopal episode? So in your history, what are all the things you need to ask about the syncopal episode? Key things, or, important things. Guys, get typing. Okay. So whether the syncope is whether the syncope is at rest or is induced by exertion. Additional history of palpitation, chest pain, important. And family history of sudden death, somebody says, very important. Okay. Excellent. So you've got some of the critical points, which is whether the syncope happens at rest or on exertion. Exertional syncope should not be ignored. The exertional syncope should be given the respect that it deserves, because this could indicate a cardiac cause of syncope. Okay, so it's important to ask about the what the patient was doing at the time of syncope and whether there was any associated or preceding palpitation or chest pain. And of course, family history, then any previous history of congenital heart disease. Say this is a post-operative congenital heart disease patient, then your suspicion will be much higher that this could be a cardiac cause of syncope. Okay, so let's see what we have left uncovered. Again, when with regards to the syncope, a few of the other things we have to think about is neurological things as well. So you have to ask about seizure-like activity. So were there convulsions? Was there a post-ictal type of state? Okay, so neurological things also need to be taken into consideration. In addition to the cardiac history, neurohistory also has to be elicited. Okay, did the episode occur? What were the trigger factors? Also an important thing. So, apart from exertion, there can be specific trigger factors which are associated with certain diagnoses. So can anybody give me examples? What am I talking about here? So when I say apart from exertion, correct, right? So long QT syndrome is what we are specifically gunning for. So things like diving can precipitate or ventricular tachycardias in certain type of long QT syndromes. Similarly, loud noises. So these are all specific things to look for in terms of trigger factors. Very good. Then, of course, we ask about the other things. That is, in addition to the cardiac trigger factors, things like standing in a crowd, overcrowding. These are all triggers for vasovagal syncope, stress. Then, like we discussed, situational things like swallowing or passing urine. And we ask about postural change associated with the syncope. Chest pain and palpitation, we have already mentioned. Neurological problems like seizures, headaches, some visual issues, ataxia. Another important thing is history of injury. So it's very rare for a patient who had vasovagal syncope to fall down and sustain a fracture, for example. Okay, it's very rare. It's very unusual. Because usually vasovagal syncope gives some warning. There is some dizziness. The patient often starts looking for support and doesn't fall down so quickly. Whereas this is not the case when the syncopal episode is due to a cardiac arrhythmia, for example. Cardiac arrhythmia can be very sudden and very quick. So if a patient has sustained injury like a fracture or a serious injury because of a syncopal episode, one needs to take that seriously and look into it to make sure that there is no pathological cause for that syncope. Okay, so we've covered everything now in terms of the history, that everything that we would like to cover, ask about. So what further evaluation is required? Now you've done history taking. Next, you have to move on to physical examination. Okay, so in physical examination, it's the routine cardiovascular examination that you would do, looking specifically for left ventricular outflow tract, murmurs perhaps. What is the other thing you would pay specific attention to at the time of examination? Some other things apart from murmurs. So what are all the things you would pay attention to at the time of physical examination? Good, very good. So heart rate and blood pressure, very important. Okay, so heart rate, because you want to elicit or you want to detect things like congenital complete heart block or some form of tachyarrhythmia. Also assess the rhythm to make sure that it's a regular kind of sinus rhythm. Blood pressure. And when you're taking blood pressure in patients with syncope, particularly when it sounds like vasovagal syncope, what you need to do is do both lying down BP and standing up BP. Okay, so normally you would lie the patient down, take a blood pressure, okay, lie them down for some time. It's not just lie down, take blood pressure, get up, take blood pressure. Okay, so lie them down for some time, and I would say at least about 10 to 15 minutes, you must have them lying down. Okay, and then get them to stand up and then take the blood pressure to see what happens with the postural change. So you need to spend some time doing it. So what is a significant difference with postural change? What would you define as a significant difference? So when the patient is laid down and then you stand them up and take a BP, what is... Okay, so usually it's more than 20 systolic or 10 diastolic. Okay, so this is not correct. Yes, fall in the BP, systolic BP of more than 20 and diastolic BP may be more than 10, but systolic is what we pay more attention to. A fall in systolic BP of more than 20 should indicate postural hypotension. Okay, so once we have done all of this, then we can go on to an ECG. So usually when you have a very typical history, a very satisfactory clinical examination, then the only investigation that may be required is an ECG, and that is more for reassurance rather than anything else. Okay, so an ECG to look for sinus rhythm, to make sure the child has an adequate heart rate, and to make sure there are no obvious signs on the ECG of things like long QT, Brugada, etc. Okay. Tilt testing is something that we don't do very commonly here. It's done a bit more in the West, I suppose, but often a good history and examination is perhaps adequate, to rule out pathological syncopes and to make a clinical diagnosis of something like a vasovagal syncope and to institute some management. We routinely tend to do echoes on almost any patient who crosses our doorstep. So a lot of these patients get echoes done, but actually an echo is not indicated unless you have some abnormal clinical finding, cardiac finding. So next, what are the treatment options in these patients? What are the things that you would advise? So you have this patient, you diagnosed vasovagal syncope. Yeah, reassurance, good. First of all, you have to reassure the family is very common and nothing to worry about. Yes, hydration is important. Perhaps increasing salt intake, yes, can help. So this is what we all initially do. And then we tell them, if the episodes are, continue to be troublesome or they increase, please come back to us. And then we can see if any medications would then help. So under the medical therapy category, beta blockers and fludrocortisone are the two drugs that can be used. Beta blocker is believed to help with, I told you that the mechanism is there is an initial adrenergic surge followed by a vagal, response. So beta blockers are useful to actually suppress this adrenergic surge. And fludrocortisone obviously causes some water and salt retention. So both of these can be useful in treatment of these patients. Okay. It's rare to find such troublesome syncope. Most often just reassurance and, a general advice is adequate. Okay. So this is, a typical case of vasovagal syncope, which constitutes about 3/4 of all the patients that we see with syncope. Now we move on to another scenario. A 16-month-old baby is brought to, to see you. Very distressed parents who are really upset because it's their infant. And basically the child has had multiple episodes of fall. So essentially the child, is now walking around. He's a toddler. So he started walking around and he keeps banging into things. So usually when he hits an obstacle, he becomes quiet and, pale and falls to the ground. Pretty much, which is very scary episode for the parents. But then he recovers spontaneously within a minute or so. So what do you think is going on here? What are these episodes typically? Yes, excellent. So these are typical reflex anoxic seizures. And usually they are relatively benign. Okay. So what are the things that can be used to treat this child? What may be helpful in this setting? Anybody? So here what happens is that, the pain stimulus causes a vagal response and the patient becomes very bradycardic and, pretty much has a period of no cardiac activity. What is IDA? Iron deficiency anemia. Okay, yeah, perfect. So, treatment of anemia sometimes is known to help these patients. So as a long-term therapy, treating the anemia with iron supplementation seems to have a positive effect on the episodes of reflex anoxic seizures. So, the underlying mechanism is vagal stimulation. Okay, so you have profound bradycardia, significant pauses. Usually these patients don't need anything doing. We do Holters on them sometimes. Very rarely we find really long pauses on the Holter, and that really scares us. And they end up with pacemakers. Very rare, but sometimes has been done. Okay, so generally what you would do is an ECG, a blood count, whatever, check the hemoglobin, and we may start them on iron therapy. But very, very rarely they may require pacing. Okay, so next scenario, a 12-year-old brought to emergency from school. So basically, his parents have been called to school by the teachers. The teachers have called them because the patient, the 12-year-old has collapsed and lost his consciousness. Okay, so what are the questions that you would like to ask? it's a similar process to what we have done for the previous cases, but what are the, it's practice for you. What are the questions that you would like to ask? Okay, that's right. So what was he doing? Was he at rest? Was he standing in assembly? Was he playing football? And, what is it that brought on this episode of loss of consciousness? Then, of course, we have to know whether the patient is awake and conscious when he comes to us. Assuming he's awake and conscious when he comes to us, we can ask him about any preceding palpitations or chest pain, and also any other prodromal features that would suggest. If he was standing in assembly, you would ask him about nausea, visual disturbances, blah, 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 blah. And if he was playing football, obviously, then you're more concerned about chest pain, palpitations, any family history of sudden death, and also any previous cardiac problems. Okay, so let's see if we've covered everything. What was he doing? Was it associated with exertion? Was there any change in posture? Any prodromal associated symptoms? Was the episode associated with seizures? Okay, same stuff. History of pre-existing cardiac disease, family history of sudden cardiac. So it's a fairly standard pattern of questioning that we're following for all these patients. So then on asking all these questions, you get the following story. The episode happened during PE class. He was playing football. He experienced some chest pain prior to the episode. And then he had this episode of loss of consciousness. Sudden, he has no recollection what happened. All he can remember is he was playing football, had some chest pain, and then it was only when he woke up that he realized he's had a faint. Currently, he has no symptoms, he has no chest pain, and he's totally fine. Okay, so what do you think of this history? Yes, okay. So what do you think of this history? Well, yes, he has had syncope. Oh, okay, rule out HOCM, somebody says, okay. Yeah. So this is basically an episode of chest pain followed by syncope related to exercise. Okay, so this is not something that we would just call vasovagal syncope and forget about it, right? So this is something that we would take seriously because of several reasons. One, he was playing football, exerting himself when it happened. Two, he had chest pain before it happened. So all of these are red flag, symptoms. So these are red flags for you to think about this and not dismiss it as just a vasovagal episode. So we think that, yes, possibility of cardiac syncope. So now that we think it could be a cardiac cause, it could be either arrhythmia or it can be a structural cause. So what are all the investigations we would do now? Routine investigations, what are to rule out arrhythmia and structural problems? Simple stuff. We do it day in and day out. Come on. ECG and echo, right? So that's what you would like to do. You'd like to do an ECG and an echocardiogram. And then based on his symptoms and the findings, you would decide on whether you want to put him on a treadmill and do treadmill testing, because these symptoms were associated with exercise. Sometimes when symptoms are associated with exercise, we exercise the patient to see if the symptoms come back. At the time of the symptoms, we also want to see what is happening with the ECG and the blood pressure, and whether we can actually elicit the symptoms. Sometimes we do Holter monitoring because maybe that ECG is normal, but we are suspecting some intermittent arrhythmia. We may want to do Holter monitoring. Okay, so this is the range of investigations we can carry out, which is ECG, echo, plus or minus treadmill testing, plus or minus Holter. Okay, so this is the ECG of that patient. So can you tell me what's going on here? What are the things that may concern you on this ECG? What are the things that may concern you on the ECG? Okay, very good. Somebody says LV strain pattern. Okay. So there is LV hypertrophy. LV hypertrophy is a fairly common finding in, like, especially in adolescent children. But the thing that's more worrying is the inverted T waves that you see in V5 and V6. Okay. So normally the left lateral leads should have upright T waves. So there is not only LVH voltage criteria, but also there is inverted T waves. And that would indicate that probably this LVH is actually genuine. It's not just a ECG finding, that, but the patient actually has LVH. Okay, so then it says it cannot play the media. I'm really sorry, guys. I should have checked this. But, I think even the still kind of shows you what we want to see. What do you think from this echo image? What can you see? Anybody? Okay, asymmetrical septal hypertrophy, that is usually typical of hypertrophic obstructive cardiomyopathy. When you Doppler it, you see a double envelope where you have a significant gradient, first of all, 120 peak gradient across the LVOT. And this exponential increase in the gradients that you see, this sort of a pattern that you see this also in tetralogy of Fallot when you have infundibular stenosis. This exponential increase indicates dynamic or muscular obstruction, right, in the outflow tract. So here in the left ventricular outflow tract, you have this dynamic exponential increase. What does this mean? Exponential increase means that towards the end of systole, the degree of obstruction increases much faster. Okay, so there is a degree of obstruction at the beginning. The more and more the heart is contracting, the obstruction is increasing more quickly. Okay, that's what it means. So there is an exponential increase in the obstruction. So that's what this kind of a trace indicates to us. So this indicates that there is muscular obstruction, as is seen in HOCM. Okay. So now, what next? So obviously this patient has got HOCM, which looks fairly significant. He has got a significant gradient that needs addressing, plus he has had symptoms. Okay. Now, in HOCM, the symptoms can be due to two things. One, it can be because of the mechanical obstruction. He has got significant LVOTO, but it can also be because of ventricular arrhythmias. So I think it makes sense to actually Holter him to look for occult ventricular tachycardia. If there is nothing to find, I suppose then you would go ahead and address a structural problem. If there is something to find, you have to think about, in addition to the structural problem, you also have to address the electrical issues, like an ICD may be required, whatever, needs to be done for the ventricular tachyarrhythmia. So, you have to do a septal myomectomy or alcohol ablation for the actual obstruction, screen his family, like I said, Holter monitoring, and then treatment of the arrhythmia as well may be necessary. Okay. Dagger-shaped gradient. Oh, never heard of that term, but yeah, it is a dagger-shaped gradient, and that's because of exponential increase in the gradient. Okay. Next scenario, 6-year-old, recurrent sudden falls over the last 6 months. So initially the parents just thought the child was a bit clumsy. Last episode was a significant fall and there was a cut over the forehead. It required stitches. Okay. So what do you think of this? 6-year-old. First of all, the age is a little unusual for vasovagal episodes. Usually vasovagal episodes we see in slightly older children. So that's one of the things. The other thing, of course, is that, there's a significant fall with injury. So, we do think, wow, this is quite sudden then. The fall is quite sudden. Okay. So it could be cardiac. So you ask the usual questions, no specific trigger. And in this patient, there was no significant exertion. It's a 6-year-old, so he's always playing around. So parents could not pinpoint anything and say, this is what happens before the episodes. Now, what other important history must you ask? So you've asked about the episode, the usual stuff. which you've already mentioned before in the other case scenarios. But in this case scenario, it's important. It is family history. Okay. So when you ask about the family history, they report that they lost their first child at the age of 2 years of an unknown cause. Okay. So suddenly the child died at 2 years of age of an unknown cause. So what are you thinking now? Here is a child who's had a sudden episode, has having multiple recurrent episodes of syncope or loss of consciousness, sometimes resulting in significant injury, and there is a family history of sudden death. Yeah, so you think this could be some type of arrhythmia, okay, which runs in families. So now you need to carry out an important investigation called the ECG. So what do you think of this ECG? First of all, you wonder whether it's in sinus rhythm. But actually, there are P waves preceding the QRS complexes. I'll just point them out to you. I'm not sure whether you can see my arrow. I think you should be able to see my arrow. These are P waves. They're a bit indistinct, but they are there. You can see them here also. So what do you think on this ECG? What is kind of striking? What are the abnormalities? QRS axis is a bit abnormal. So lead 1 is negative, AVF is positive, which is right axis maybe, yeah. He's a young chap, so, he's only 6 years of age. Yeah, somebody has raised the issue of long QT. If you see the corrected QT interval is 490. 490 is it's a boy. So 490 is a little prolonged for a boy, okay. Even for a girl, it's a little on the long side. And quite importantly, if you look at the T waves, they look very abnormal. So in long QT, often you find abnormal T waves. Okay, so morphologically also the T wave doesn't look normal. Okay, so this patient actually had long QT syndrome, and his sibling also probably died of that long QT syndrome. Okay, so if you look, the long QT interval is prolonged. Obviously, you have to manually calculate the QT. In patients with suspected long QT syndrome, often we do Holters. And we look at the QT variation at different heart rates. So you have to do, QT, calculate the QT and average at the mean heart rate, the minimum heart rate, the maximum heart rate, to see what happens to the QT. Does the QT shorten enough with the higher heart rates? So that's one of the things. A Holter can be useful in long QT syndrome patients who are borderline to look at the QT variation with heart rate. Okay, so with long QT syndrome, how would you treat a patient with long QT syndrome? What is the ideal treatment for a patient with long QT syndrome? Probably an ICD, right, to prevent cardiac death. But in our children, we don't really have we can't put an ICD so easily because it's got its own morbidity. There are, inappropriate shocks. You need to upgrade the generator and the leads very often. So it's a huge undertaking. So initially, usually what we do is we give drugs. But the fact that this patient has had a sibling that has died and is now having symptoms is a worrying thing. So you probably will have a lower threshold for an ICD, but you will probably treat with medications like beta blockers first, and then see what their response is before you decide on an ICD. So these are some of the common triggers for long QT, like we said, loud noises, diving, swimming, etc. Okay. So now we come to the workup of syncope. So usually for most patients with syncope, just a history, physical examination, maybe an ECG is more than enough. Majority of syncope patients, you can come to an adequate diagnosis, reassure them and send them away. Okay. Then in the proportion of patients in whom you're not totally happy with the history, or your examination has given you some abnormal findings, or on ECG you're having some concerns, all those patients, you will then further investigate them. You can do an echo, exercise test, maybe if it is exertion related. And then depending on the results of that, say for example, in the HOCM patient, you did an echo and you had the diagnosis, right? You don't really need to do anything else. So then you just have to treat the problem. But if suppose you don't get anything on the history, examination, ECG, echo, exercise test, that leads you to the diagnosis, but still you're worried about this patient, this is not sounding like a routine neurocardiogenic syncope, then you have to investigate further. Okay, and when you're investigating further, especially when the episodes are recurrent and frequent, then you may want to do longer recordings. An ECG may not capture the problem, so you might go for a Holter recording or an event recorder. Holters can be done even for 7 days. So these are, for a period of time you can record the ECG. There are some patients in whom the episodes are happening very infrequently, once in 3-4 months. So you can't put them on a Holter or an event recorder. For those patients, you can actually implant a loop recorder, which under the skin, like a pacemaker, but it doesn't have leads. It's just a small little thing. It's a bit like a pen drive. So those USB drives you get, which are like a finger, so about that length. It's a flat little thing. You just make a subcutaneous pocket and you put that device in and you stitch it up. So it stays with the patient throughout. They have an activator, so they can activate that device if they have any symptoms. The device itself has some presets. So automatically also it will capture abnormalities. Then you can read that device remotely and you can get data from that device so that you can pick up any abnormalities in the rhythm or rate, any abnormalities, or you can look at the heart, the activity, the electrical activity at the time of the symptoms. So when the patient has a symptom, suppose you can show sinus rhythm, and only normal cardiac electrical activity, then you can reassure the family that yes, the symptoms are a pain, but the heart is normal. There's no cardiac abnormality which is responsible for the symptoms. So this is a useful investigation in really troublesome syncopes, which happen over a long period of time. Okay. Okay. Now I think I need a drink of water. Do you have any questions so far? You want to interact? Ask me anything. No promises that I'll be able to answer the questions, but you can ask. Is it clear so far? Are you getting a broad idea as to what this is all about? Okay, good. Right, so next we go on to another scenario. Okay, so I won't read it. Okay, somebody's asked a question. We'll come to it at the end. Okay, I'll remember your question. You can ask it again also, even in case I forget. So, you have this scenario where you have a 17-year-old who's known to your department, known to have congenital heart disease, presents to A&E. It's a 24-hour history of palpitations. Okay, so he's come because of the palpitations. He's not feeling very well. And, you're just calling him in to be examined when he collapses. Okay, when he gets up from the chair, he collapses. So then immediately he's laid flat and his legs are raised and he quickly recovers consciousness immediately. So what would you do now? He's briefly lost his consciousness on getting up. We put him on the floor, put his legs up, and he's become conscious again. So what do we need to do now? What do we need to find out? He's come with palpitations and he's a known CHD patient. We need to put him on we need to put him on a monitor and perhaps quickly get an ECG. Okay. So because we are thinking he's a post-operative CHD patient, he could have an arrhythmia, and that arrhythmia might have made him, have low blood pressure. So when he got up, he lost his consciousness briefly. Okay. So he's a patient who has undergone a Senning operation or an atrial switch operation for TGA about, a long time ago, 14 years ago. When he was 3 years of age, he had an atrial switch operation. Okay. So now what are the possibilities you're thinking of? So a patient who's had an atrial switch, what are the type of arrhythmias that they can have? What are the various types of arrhythmias they can have? Yeah, commonly you would expect atrial arrhythmias. Some of them can have ventricular arrhythmias as well. Okay, so atrial arrhythmias, ventricular arrhythmias. What else can you have? Right. Sinus node disease. Very good. We have covered everything now. Sinus node disease. And then heart block as well. The heart block, particularly in those patients who have had a double switch. Okay, if you have CCTGA and you've had an atrial switch, you know that CCTGA patients are prone for getting heart block. So just plain atrial switch in the absence of CCTGA, heart block may not be that common. Sinoatrial node disease is more common. Sinus node dysfunction is common. Okay, so these are all the various things that are possible. So then, you attach monitoring, you measure his blood pressure, because it looks like this is an unstable tachyarrhythmia, right? So he has a tachyarrhythmia possibly, and he has probably got hypotension associated with it. And that's why he has fainted when he got up. Okay, and he recovered quickly. So this would be an unstable tachyarrhythmia. So normally the treatment for this kind of unstable tachyarrhythmia is cardioversion, right? When you have a patient with stable tachyarrhythmia, you can try medical maneuvers and things like that. But usually when they come unstable like this, you will cardiovert them irrespective. Okay, you just remember your PALS or your resuscitation course. That's what you will do. Okay, so anyway, now that he has recovered his consciousness, he's been given a little bit of adenosine, and you can see that, the underlying rhythm, he's got some form of atrial arrhythmia going on. Okay, so he's got, an atrial rate of about 180 to nearly 200 with variable conduction. So this is what is causing his problem. So, if it is atrial flutter, you can cardiovert them. But anyway, any atrial arrhythmia, even before you get an ECG, any arrhythmia with low blood pressure, you don't worry about what anything else. You don't worry about exactly what type of arrhythmia it is. But when you have an arrhythmia, which is a supraventricular arrhythmia with low blood pressure, your first strategy would be to cardiovert them. Okay, so although normally when a patient is stable and they've had long-standing arrhythmia, you worry about clots. When the patient is unstable and they have arrhythmia, you just go ahead, you have no choice, you just go ahead and cardiovert them. You can do an echo, either transthoracic or TE, to look for clots, and you can heparinize to help you. But often you may not have time to anticoagulate them. Okay, in the long term, obviously, this patient will need anticoagulation, antiarrhythmic medication, maybe ablation. But, just to give you a flavor of these sort of patients can also come in with syncopal episodes because of arrhythmia and the related hypotension in the context of an abnormal complex congenital heart disease post-surgery. Okay, so we discussed this already, sinoatrial node dysfunction, heart block, like I said, only mainly in CTGAs. So this is also a scenario of the kind of patients we can see in cardiology practice with a syncope. Okay. Another patient, 10-year-old, a history of recurrent syncope over the last few months. Also, parents are saying that he's becoming more tired, unable to keep up with his peers, gets tired very easily nowadays. So again, you have to go through the usual, history of all that's, what are the possible causes. This could just be a vasovagal thing, of course, but you have to rule out, as per usual, all the nasty causes of syncope. So you examine the baby, and this is what you find. Okay, it's a 10-year-old. So in this examination, what is striking you? What is strikingly abnormal? Correct, heart rate. So heart rate is a little low. So what are you thinking now? This kind of history, yeah. So the child is bradycardic, and the child has history of syncope. So one possibility could be some form of bradyarrhythmia, right? So it could be heart block. You know that things like congenital heart block, they can be asymptomatic for a long time and undetected. Okay, so you would do an ECG. So what does the ECG show you? So does the ECG confirm your clinical suspicion? Yeah. So if you see, there is complete AV dissociation, right? So first of all, there is bradycardia, profound bradycardia, and there is also complete AV dissociation. So this is complete heart block. It's a congenital complete heart block, most likely, undetected so far. Now the patient has symptoms. This patient will require a pacemaker, okay? Because patient already is having syncope. So class 1 indication for a pacemaker. Also this, getting tired easily and not keeping up with the peers, that is also an indication. If there's any functional limitation, then you would go for a pacemaker. If, the other things you would look for generally in any patient with complete heart block to decide on pacing, you would holter them. You look for ventricular ectopics. You'd also look at the QRS duration. All of these will give you an idea as to when is the right time to pace these patients. Because some of the patients in the early neonatal period, early childhood, they may be pretty stable, even though they are in complete heart block. And you don't want to commit them to a pacemaker so early on in life. But you have to keep a close eye on them and keep monitoring them to decide on when to go for a pacemaker. Okay. So earlier we had discussed there are mechanical causes of syncope and there are arrhythmic causes of syncope. So what are all the mechanical causes? We saw HOCM, right? Similarly, aortic stenosis is another mechanical cause. So there are some patients with valvar AS who present only with symptoms. It's very unusual nowadays, but it can happen. So severe LVOTO. Similarly, anything that causes low cardiac output, severe PS, pulmonary embolism, severe MS, all of these can cause syncope. Similarly, pulmonary hypertension. Somebody mentioned it earlier on in the discussion. Pulmonary hypertension can also cause, especially when there is no associated cardiac problem, because there is no shunt, right? So when you have severe pulmonary hypertension, you don't have a shunt, then you have you have hardly any high pulmonary vascular resistance, hardly any cardiac output. So that can also result in syncope. These kind of patients with pulmonary hypertension who have syncope, you end up doing some procedure like an atrial septal stent or, a pot